Hi everyone, am I audible?
Yes,
Okay, fine. Let's talk about the lab data and SAE reconciliation today. The reason that I've discussed with you all regarding SAE definition and the adverse event definitions, systems that we use, it's all because in clinical data management, the data managers will review every data point, whether it's lab data, adverse event information, investigator product information, every data point that is being entered in case report form will be overseen by or will be reviewed by the data managers. So now we have seen a normal discrepancy, like what kind of discrepancy can happen. This the discrepancy is not just for a single parameter. The discrepancy can happen throughout the data points, whether it is or adverse event. Discrepancy can happen in any data point. Now, there is something called reconciliation. Reconciliation is nothing but comparison the data between the two different systems, comparing the data between two forms, comparing the data between two logs is called reconciliation. Now, why do we do the reconciliation? Right? Sometimes we read exams and we tell, no, I wrote exactly what is there in the textbook. That means you're trying to reconcile even your answer sheet with the question, I mean with the notebook, I mean with the textbook, and you're trying to say that you have written everything, right? So that means you're trying to analyze that you're not made mistakes, because the textbook is your source document. That means something that it's a everyone sees as a correct book. There are no mistake in that one. And now you study from there, you read from there, and you write an exam, right? That's what the exam. Same way that whatever the data points that we are generating from the patients, first we will get in the source format, such as like lab reports. You give the blood to you take the blood from the patient and give it in the laboratory. They will give the results. That is the source document. And you ask the patient what happened to him, like, and if he experienced any fever, any nausea, vomiting, anything you tell, the site will be entering on the adverse event form, nothing but source document. From there, you're gonna enter all the data parameters in the case report form. You're understanding my point? So that means during this time, when I'm entering the data from source document to case report form, there might be issues, or there might be chances that I've entered incorrect information, I've entered wrong information, I've entered spelling errors, I missed some information. This is one type of reconciliation. This is nothing but we call source data verification. And there is also other type of verifications. During my last session, I told you people there are two different systems that we use in the clinical data management. One is the safety database, and the second one is clinical database. How many of you remembered? I'm not sure. So in clinical data management database, we enter all the data parameters, but in safety database, will enter only the adverse and serious adverse event information, right? So now clinical data management database will be overseen by data managers, whereas safety database will be overseen by pharmacovigilance team. Now you might think, like, why are we talking about two different systems? I'm not sharing my screen yet, but you might think, or you can just give a thought why I'm talking about two different systems. We are talking about two different systems because there are some of the data points will be reconciled between these two systems. You name it. When I'm entering all the information, you might think, why should we reconcile from the safety database? Um, now, okay, So now, when we were doing bachelors, um, we used to study every subject, not depthly. There was one of my friend, when I used to study different books for one subject. Like, let's take an example of microbiology. And in microbiology, you have a bacteriology, you have parasitology, you have mycology, and you have virology, and other parameters. So what I used to do in my master's first year, I used to read different books for each chapter. Like virology, one different book; parasitology, one book; mycology, one book; and virology, one book. But my one of my friend in first year, he used to read only one book, only one small book. I used to wonder, like, how come, man? You don't get much information that you'll only get some headings, some basic information you'll get in that book. How you gonna pass? And you know what? He passed. He really passed that. And when we went for second year, each subject was pathology and hematology, histopathology, all these. And my subject, my final year subject was the microbiology, for example. Then what I used to do, I used to study almost 10 books for microbiology. We used to study everything. Okay, because in first year we used to have all major subjects like pathology, microbiology, a lot of other subjects. So we don't have to focus on one subject. But when we come for second year, whatever subject we were doing specialization, we read only that book. You understood? So here, clinical data management database contains all the information. It's a small book kind of, and it contains all the information. But whereas safety database contains specific information. It contains only adverse event information. It will not contain any other information. It is a bunch of information it contains regarding the adverse events, right? I try to give an example. I'm not sure if you got, but let me tell you one more example. um how will I tell? Okay, so if you see MS surgery, and in MBBS they read all the books, like they read about anatomy, physiology, pathology, microbiology, ophthalmology, OBZ, surgery, medicine, everything till final year. But when they go for the post graduation, they read only specific subject because they need to know everything about it because they're specializing it. Same way, the safety databases are something but specialization of adverse event information. Then you might think, so when you say that the safety databases talks about the safety database contains information about adverse event, and when you also said safety database are managed by pharmacovigilance, but I am a clinical data management personnel, why should I know about this one? True, why should we know? Because there is a change, or there is exchange of information. There is information that is being entered in this both the databases. So when I'm entering the same information in two different databases, that means uh, the information should be same in both the systems. But sometimes, when it is being managed by two different people, there might be errors. And that's what we're going to see, the SAE reconciliation. And that's what the whole story about what I said for last 10 minutes. Good. Any questions before I just good. So, as per International Conference of Harmonization, good clinical practice, it is expected that the short-term adverse events rates will be characterized. And what happens here, whenever the drugs might have some anticipated risk, some kind of unknown risk, some are known risks, some are the normal concerns. Yeah, we all know the definitions of it. What is an adverse event? What is a serious adverse event? So now, what is the importance of safety data management? Why safety is the critical parameter? Because dying with the disease unavoidable. We cannot stop that a person die with the disease, but dying with the wrong medication is unacceptable. In order to ensure that no one dies with the wrong medications, what we do, we try to capture, or not we just try, we're gonna ensure, we're gonna make sure every adverse event the patient experiencing during the clinical trial or even after release a drug into the market, and every SAE data point or every serious adverse event the patient experienced, will get gather all this information, because it is something concerns the patient life, right? And the same serious adverse event data will be recorded in both the safety and the clinical databases. Take this point. Everyone, take this point. Is recorded in both the safety and the clinical databases. It is essential to understand that this data is submitted to the regulatory authorities, agencies, both end of the study and the subsequent aggregate report. Aggregate reporting means they collect all the data points every 6 months, every 6 months, 9 months, 12 months, every SAE the patient experience. They combine all the reports and see that what is the most common, what is the most frequent, what is most critical serious adverse events patients are experiencing because of this medication. You understood? So what is the most common, critical, and frequent serious adverse event the patients are experiencing, and that is the guys, just let me drink water. Okay. Then, and in addition to the reports, death listings, SA listings were submitted to the regulatory agency, because every serious adverse event has to be reported to the regulatory authorities in during the clinical trial. Not only during the clinical trial, even once the drug released into the market. So the safety reporting is done in case where when a trial participant experience any of the following, that is adverse experience with the drugs, adverse drug reactions, unexpected reactions, serious adverse drug reactions. So the classification that there can be different factors. One is expected, unexpected. That means, can someone tell me what is this expected, what is unexpected? Come on, you all need to talk. No idea? Okay. So, expected something that we already knew. We all remember, you all know, right? Whenever the patient participate in the clinical trial, the investigator would inform every adverse event the drug can cause. Apart from that, there are sometimes patient experience adverse events which we never knew, or which doctor was not aware of it, right? So those we say unexpected. You will say, no, we didn't expect this adverse event, we thought mild fever, but patients are experiencing serious fever. We knew there is a chance of getting the mild fever, but now when we look at the patients, everyone is experiencing the severe fever. What is expected here? The mild fever. But what is unexpected? It became severe. The severity, there is a difference between the severe and the serious. So severe is nothing but intensity. That means how much it affected the patients and all. The casual relationship, there's the relationship is like many of the times is that, right? And I'm having headache since the time I took that medication, and I'm feeling nausea since the time I took that vaccination, or I'm experiencing headache since the time I had that syrup, right? We always try to link the uncomfortable or discomfortable concerns that we have after taking any medications. We try to link to the medication because we think it might be the reason, right? So the causal relationship between the drug and the drug and the event is nothing but adverse event. Sometimes there will be a relationship between the drug and the event. Sometimes there won't be any relationship with the drug and the event. So what is not an AE? Medical or surgical procedures. It's not called AE. Pre-existing disease, which do not change. So what is the safety reporting? All serious adverse events should be reported immediately to the sponsor, except for those SAE that are protocol or other document identified as not needing immediate reporting. So here are two things. One is that every serious and all the serious adverse events should be reported immediately to the sponsor, except the events that the protocol, other document like investigator brochure says that this event or this serious adverse event, if the patient experience this kind of serious adverse event, you don't have to report immediately because there are some exceptions. The immediate report should be followed promptly by detail within the written reports. So when it is safety reporting performed, the investigator should also comply with the applicable regulatory requirements and adverse events laboratory abnormalities identify the safety evaluation. So take this note. The safety reporting timelines. This is one of the frequent asked question in the interviews that why what is the timelines that we are supposed to follow for the safety reporting? Take note of it, guys. So what is a follow-up, right? We should always know what's happening to the patient. How is he doing? Is he alive or dead, died? Or what is the serious adverse event related to because of the drug or any other reason? And how is he doing? And every information should be taken till the serious adverse event till the serious adverse event subsets or whatever the results. Now, the essay is followed until safety, resolved, or just to be no longer clinically significant. Can someone tell me what is the clinically significant? Come on, guys. Need to talk. That's why I'm asking questions. Okay, whatever. So, clinically, the patient last visit according to the study protocol is not required. So now, the roles and the responsibilities of the safety data managers. So extracting the listing from the safety database and the clinical database. Extracting the listing means extract or download all the serious adverse event information that was being entered in the safety database and the clinical databases. So reconciling the mandatory agreed upon the data point. So we will look into that if the both the systems has all the serious adverse events or not, or sometimes it is missing. And that's what about the reconciliation. Now, let's see. Okay. So safety database. Essays from the clinical trials and marketed products are supposed to be reportedly direct to the safety group or the safety coordinator. That means all the serious adverse event information from a clinical trial and marketed products. That means that drugs that are released that is released into the market are supposed to be reportedly directly to a safety group or the safety coordinator. And because of the detailed information related to the case of a serious event, and because of the reporting requirements, the safety groups requiredly use a specialized database to enter all the databases information. Now, if you see the clinical database, a collection of all the clinical trial information per protocol from all the patients life of clinical trial, typically organized cases. Now, SAEs that are occurring during clinical trials will be reported in the data management databases. Only guys in clinical data management database, only SAEs that are occurred during the trials. So take okay, guys. So these are the systems like how you have a different company mobiles like Samsung, Nokia, or iPhone, everything, right? So these are the different companies. So what happens here? The data will be entered from the adverse event monitoring form and to the safety databases, and from the in clinical data management database, the data is being entered from the case report forms. And so this will be so again I'm saying in safety database the data is being entered from the adverse event monitoring form, whereas in clinical database the data is being entered from the case report forms. Now, so there are wait, just give me 1 second. I'll reshare. So there are different data points that we will be doing the reconciliation. So sometimes people compare with, okay, he plays cricket better than you. So what is they're comparing? They're trying to compare that someone else play cricket better than someone else. So likewise, we compare the both the systems with the sum of the data points. Now let me show you all that how it is. Yeah. So these are the data elements that we will be used to do the reconciliation. So that means in both the data systems, the protocol details should be correct. That so it's also giving the other information or other information to us that in every case report form, in every serious adverse event details, the protocol entering the protocol details are mandatory. Now we will see in safety database protocol number 12345. In clinical data management is 12345 or something else. So if it is same, that means it's passed. Then next, the subject identification. In a clinical trial, for every subject we give the one identification number. So that is correct or not. Demographics field like patient age, gender, ethnicity, race, everything. And dosing details. How much medication the patient has been taken. So is it same in both the systems or not? Event case number, every case will have a number that will be entered in the systems, and disposition details. So if all the details are same, if the details are correct, then they would say there are no issues, there are no discrepancy between the both the systems. But what are the common errors that happens? Surgery noted in one database is supported by the condition. No, this is okay. Onset and stop dates are missing in both the systems. And that means we will generate a query. And if event dates are completely outside when comparing two databases. So the two database they've checked and event dates were completely out of date, outside the when the event has been occurred. So in that cases, we will generate a query. You might think, so whom you will generate a query? If there is an issue or if there is an error in the safety database, we will generate a query to the pharmacovigilance team. If the issue we seen in the clinical data management database, nothing but clinical database, we will generate a query to the clinical databases. and the stop date is missing for event, outcome is resolved, we'll generate a result. So likewise, wherever there is an issue, we will generate a query. So now let's look into the one of the case study here. A thin 9-year-old male, no, a 9-year-old girl, Mary, is consented and enrolled is having the blood drawn using 21 gauze needle attached to a vacuum. The startled child screams and moves, dislodging the needle, and pressure is immediately applied, but a hematoma 12 in diameter results. Distal pulses are intact, there is no sinuses, and movement of the extremities unpaired. Now, what happened? They're trying to collect the bed from the baby, and she got scared and screamed, and she tried to, move her hand, which has dislodging, and there was hematoma occurred. Now let's look into that. What is a site responsibility? They complete the adverse event information on the case report form, then they evaluate the child in 7 days, understanding whether that becomes serious, I mean that whether that is reduced or resolved. The lesion is published but resolving, but 14 days later the lesion is completely healed. See that. First they check for 7 days, then 14 days. That means till it become reduced, they keep checking for, they keep doing the follow-ups. Now, there is another case study. A thin 9-year-old boy, John, is consented, enrolled, having a blood drawn using the 21 gauze needle. The child screams, moves, dislodging the needle. Pressure is immediately applied, but hematoma 12 in diameter results. Distal pulses are intact. There are no signs. Mother bring the child back in 5 days with a fever. The patient experienced a fever. Lesions at the puncture site is hot, swollen, and red and tender. That means the hematoma site has obsessed with the pus. Now, so the site responsibility will be this, they continue to treat with the best clinical management. They complete the SAE form because he experienced the fever and admit in the hospital. So that means, let's take an example of, as long as the patient don't admit in the hospital, it's still called as an adverse event. But the minute he gets admitted in the hospital, we call it as a serious adverse event. So one of the definition, it says that the hospitalization is nothing but also called as a serious adverse event. That's it. Any questions? So having idea on definition of a serious adverse event is important, and what are the different databases that we use? One is important, and examples of these databases. And third thing is that why do we do the reconciliation? How do we do the reconciliation? Like the reason for the reconciliation, why should I perform, and how should we perform? To perform, what are the data elements that are important, like a protocol details, patient information, event information, demographics? So we compare it with the, okay, in the safety database it says that 1 2 3 4 5, and in the clinical database what it is. And um, also that in the patient age is 35. Okay, did we enter 35? Onset date is 65. So do we sorry, onset date is the 6th May. So do we have the same date? And that's what we look at that. So we ensure that all this information that has been entered is correct or not. So if it is correct, because if it is not correct, what happens that we might get a question from the regulatory authorities. So instead of waiting from the regulatory authorities, we will ensure that all the data is being entered and checked properly against the available databases. Good. Guys, any questions?